Medication Administration, Introduction to Nursing Concepts. This is Martha Olson. As we look at the role of the RN in medication administration, we know there's huge potential for errors, and we want to minimize that as much as we can. Knowing your math and knowing how to correctly get the dose is very important. A large part of the NCLEX test will be medication safety. Do you know your meds? Do you know how to safely pass meds? And so medication in this unit is very important for many aspects of your career. When we look at the beginning nurse, we want to make sure that we don't become in a habit or get in a bad habit of doing things incorrectly or not following protocol. There's potential for error. You can kill people by giving them the wrong dose, the wrong med, the wrong time, the wrong route. So we have to make sure that we are always concentrating, don't get sloppy and get in bad habits where we just pull medications from the Pyxis without looking at them, and try to minimize distractions during the medication pass. If another nurse tries to talk to you, either quit what you're doing and focus on what they're saying, or just simply say, I'm setting up my meds right now, can you get back to me later and we can talk about that. When we pass meds, we want to make sure that we keep the meds locked and safe, because if somebody would get into them, that could be very potentially harmful. And also we have a lot of narcotics, and we know that the Drug Enforcement Agency, the DEA, has very specific rules about double lock on all of our narcotics. Never give a med unless we have an order, and then don't carry out that order unless you're exactly sure and very clear of what you're doing and what the med is and what it's for. As we are passing the meds, we want to make sure that we scan the med and the patient or client's bracelet before we give the med. Then we want to open up that medication. If it has to be cut, that's the time that we will score that medication in half after we have identified the patient and the correct med. If we wonder if it's discolored, smells bad, feels or looks funny, send it back to the pharmacy and have them send you a new one. We always want to check expiration dates. It's kind of amazing how many meds we give in the hospital, but we can actually come across medications that have expired and have to be discarded at that time. When we think about the med pass, make sure you know your drugs. Use your drug book, look things up if you're not sure. As a new grad, it's going to take you a longer time to pass meds because you have to look up things more often, but it will come with time and with practice. So just keep looking up the meds so that you know what you're doing. If a medication needs to be given on time, and then we record it after we give it. You never want to give a med before or document before giving it. Perhaps the patient will refuse the med, or you'll get in the room and they'll say, I'm very nauseated, I don't want to take my medications right now. Stay with the patient until after the med's been taken. They may choke on it, and you wouldn't want to have walked out of the room where they're having problems getting that medication swallowed. As a school nurse, we always had to make sure that the kids swallowed their medications. Many of them would cheek them and then go spit them out in the garbage as soon as they got out in the hall. And this is also true in mental health. We want to make sure that we are looking at the mouth of that patient to make sure that they are not pocketing that medication to save for later. And then, like in mental health, they may try to overdose on those meds that they've saved. Our rules of the med pass then, if you need help, make sure you have plenty of help with you. Have lots of water and straws available when you're giving meds. Even if they are on a fluid restriction, you want to make sure that you have plenty of water. I always tell them, remember you're on a fluid restriction, you have a full glass of water to get your pills down, but don't drink all of it unless you need it. I just have it here in case you would have some difficulty and need additional water. Make sure that we only give meds that come from a labeled container with the pharmacy, so that we are not giving something that we shouldn't. Make sure that we are the only ones that get the meds out, pour the meds. If a nurse hands you a med and says, I'm running to ER, quick, can you give this to room 52? Don't do that, because you don't know, and you're liable because you're the one that gave it to the patient. Don't leave meds with the patient in their room if they're on the phone or busy doing something else, because we have no way of knowing if they would take that, throw it away, or if maybe a visitor would even come and take those. The only meds that I can think of that we leave at the bedside with a physician's order are birth control pills. Occasionally patients might have vitamins or something that they take at home that we don't have, that the physician will write a very specific order, may have at the bedside. And then we only throwaway meds. If it's not been used, we do not return it to the original container. It's easier and better to waste one small dose than to contaminate a whole container. During the med pass, again, we want to make sure that we break or score those tablets right at the bedside after we've scanned. We never want to crush a timed release or enteric-coated medication because of the potential for toxicity. A timed release is scheduled to slowly absorb when it gets to the small intestine, and if we crush it as soon as it gets to the stomach, it's going to be absorbed and metabolized and going to be toxic for that patient if we do that. So we never want to alter the packaging of that medication. Make sure that with discharge we are doing good teaching. They know what they take, when they take it, why they take it, and things that they need to be looking for or doing specifically with those medications. Many older people take medications that are altered or made ineffective with grapefruit or grapefruit juice, and they travel down to Texas and Florida in the winter and they eat a lot of grapefruit and it alters their medication. So we need to make sure we know our meds and we are teaching our patient about their medications at discharge. One of the things to stop and think about right now is if you make an error. If you get a patient medication error, as the nurse, your very first action is going to be the patient. Are they breathing? Do you need to get a set of vitals? Are they okay? And then after we assess that patient and stay with them, think about what we need to assess, what do we need to do when we call the doctor and tell him, and then what will we document in the medical record for the patient, and what will we put in an incident report. Remember, you do not write it in an incident report that or in the patient's chart that you made an incident report. And we'll be talking about this one a little more in class. When we look at Objective 161, examples of med errors, they can happen for a variety of reasons. We get tired, we're working 12-hour shifts, we've been there for 3 days in a row. When we don't follow the 6 rights, when we don't do our triple check, when we allow ourselves to get kind of lazy or bypass some of the things that are in place to keep us from making medications errors is when it can happen. Perhaps we don't scan the medication because the patient took their armband off and we couldn't find it, and it gets to the wrong patient. So follow the safety measures, take your time with medication pass so we don't make errors. We always want to identify the client by asking them their name and their birth date. If they're cognitively impaired, very young, like a pediatric, they may not be able to state their name, and so you would want to find another way to identify your client to be sure that you have the right one. Check the MAR against the name band, and then we will scan that bracelet to make sure, again, that we have the right person. Our 6 rights are listed here: right med, dose, client, route, time, and then our right documentation. And we'll be spending some time in this PowerPoint looking at some of the ways and things that we need to document with each of the medications. Our right med is using that triple check. As soon as we take it out of the Pyxis, that's our first check. We want to do 2 other checks then to make sure we have the right medication. In the Pyxis, it helps so that we only can get the right med, but the Pyxis can be set up wrong, or the meds can accidentally get in the wrong bin in the Pyxis. So we always want to look at that med on the label to be sure we have the right one. If the client ever questions getting the medication, make sure that you double check. It's usually a red flag for me that says, I need to go back and look at this med. Sometimes it's a matter of they use the trade name at home and we have the generic at the hospital, and so it's a little different. Perhaps we've had to substitute their med in the hospital because we don't carry the exact one they take, and so the pharmacist has substituted. Maybe it's a new med that they haven't gotten. Sometimes it's been that the client is getting the wrong meds, and he has now helped you to catch a potential med error by asking, what it is they're taking. When you are administering the meds, you should be teaching and saying what each med is that they're taking and why they take it. So if I hand over the med cup and it's got a Colace, I'm going to say to the client, this is that red Colace pill that you take, this is your stool softener, and do you have any questions about that medication? The other thing hospitals are really focusing on now is talking with the patient about side effects that they may have with medication. To make sure you have the right dose, make sure that we're using what comes from the pharmacy. We are not allowing anymore for patients to bring their home meds in, and we give them the medications that they bought at the pharmacy and brought with them. There's too much potential for error in doing that. Again, don't crush those enteric-coated meds. Sometimes we have to mix it with a small amount of food or liquid to get them to be able to swallow it. Many older people, we crush their meds if they're able to be crushed, and put them in applesauce or something that they can swallow. Do not put it in their favorite food because it discolors and cause a distaste to that, and then the person might not want to eat that favorite food anymore because we've altered the taste in using that to give their meds. As we stop and apply, again, those enteric-coated medications or extended-release medications are going to become toxic because the stomach is very acidic, and in that acidic environment, it can change the pH, the property of that medication, so that it gets to the bloodstream very quickly and in a very high dose. The small intestine, remember, is more neutralized from the bicarbonate that comes into that. And so that's where medications that are extended released are supposed to be absorbed and then metabolized as they're sent to the liver. When we think about getting the right client, make sure that we're asking the client to identify their name and birth date, scanning them. In the nursing home or long-term care, they may not have bracelets and they may not be scanning yet, so you would want to make sure you know your residents. Use the picture that's provided of each resident in with the MAR to get the right one. I always think of how many little old ladies that have white hair and white sweaters all sitting around the table. It'd be very easy to get them confused and potentially the wrong medications to that resident. And then the right route. There are many ways and routes to give medications, and we want to make sure that we are getting that medication. You know, instead of an eye drop, maybe it's ear drops, and we accidentally put it in the eye and cause blindness. So we want to make sure that the route is clearly identified before administering that medication. Our right time. We always have to think about the timing of medications, and many times when a physician writes the order, he will not write the time the medication is to be given. That's up to the nurse and the pharmacist to make that determination. Our medications that cause diuresis and for the patient to eliminate fluids with more urine output, we give those earlier in the day so that they're not up at night voiding. Our Coumadins are always given at 1 o'clock in the afternoon to make sure that we have a blood level for their blood clotting, their PT, INR, on the chart before giving those. Are they evenly spaced throughout the day? If this is a BID or twice a day med, is it given at 9 in the morning and 9 at night to space it out evenly? What are the effects in the timing? Again, is it with meals, or is it supposed to be given on an empty stomach? Empty stomach, we oftentimes give those at 6 or 7 in the morning when they haven't eaten all night before breakfast, so it can be absorbed correctly. Many of the side effects cause orthostatic hypotension, or they get dizzy when they stand up. And so we might give the medications just before they go to bed when they're going to be sleeping all night, and that side effect will not be as troublesome for them. And then our nitroglycerin patches, we usually take them off at bedtime, and the reason nitroglycerin is not left on 24 hours a day is because the body would get used to it, and it would become ineffective for that person because their body is used to that vasodilation property, and it won't work anymore. So we usually take the nitro off at night when the person is not going to be as physically active and potentially have chest pain at that time. The right time. How do we know? Well, we need to look them up. We need to become familiar with our meds and think about what is the best time, why is this med given, and what does the drug book say about the timing for this medication. We know that the drug class, the statins, are given at bedtime because that's when the body, the liver, is making cholesterol, and that's when the statins are needed in the blood. Medications that have to have a constant blood level, such as antibiotics or anti-seizure medications, we oftentimes will give those 4 times a day and space them out every 6 hours to maintain a therapeutic blood level for that medication. So as we think about this first part of med administration, we can see that there are many important responsibilities for the RN in safe medication administration and prevention of errors. We will continue on in part 2 looking at what we will do in certain cases. Thank you.